Hello, everyone. My name is Adrian, and I work for Medtronic. Tonight, I have the pleasure of hosting this webinar where you'll get to hear more from Dr. Lina Millan. Dr. Millan was raised right here in Atlanta, Georgia. She went on to receive her undergraduate degree from Emory University and completed medical school at the Medical College of Georgia. Upon completing medical school at the Medical College of Georgia, she completed her medical degree and pursued her residency in OBGYN at West Virginia University. Following her training, she moved back to Georgia and began practicing in Athens in 2015. Dr. Milan has an active interest in advancing women's healthcare and education across the state. She has held various board member positions for prestigious organizations across the state and is an associate professor of OBGYN at the Medical College of Georgia. Dr. Milan offers leading edge treatments for a host of female gynecologic issues, including pediatric and adolescent gynecology, PCOS, pelvic organ prolapse, endometriosis, infertility, treatment of uterine fibroids, postmenopausal bleeding or irregular menstrual bleeding, premenopausal and menopausal transition, and bladder and bowel control issues, which is what we will be discussing mostly tonight, along with a therapy called InterStim. As I mentioned before, I work for Medtronic, and that's the company that developed this therapy. While you may not know the name Medtronic, you probably know someone who's had a pacemaker, and that's what we're most known for. So without further ado, I'm going to pass the mic on to Dr. Milan, so that way you can hear more about this therapy and treatments. But before I do, just a few reminders. Everyone's computers are muted upon entry. If you have a question, feel free to type it in the Q&A box at the lower portion of your screen. All names will remain anonymous, and we will answer these questions following the presentation. Likewise, please answer the anonymous poll questions during the presentation, as well as the anonymous survey at the end. And now, without further ado, we'd like to welcome Dr. Milan.
Thank you, Adrian. It's really a pleasure to be here. Thank you so much for coming and taking time out of your very busy schedules to listen to this webinar. I hope that it is very empowering and educational for you guys. And just a little bit about our practice. Our office, Advanced Gynecology, has over 20 years of experience dealing with a host of urinary issues and concerns. I can tell you on a daily basis, we hear story after story of how urinary symptoms rule people's lives. And thankfully, over the last couple decades, there have been more advances in therapies that help patients tackle these life-altering symptoms. So hopefully this webinar will help give you some tools in your tool belt and some information to be able to empower you to make the next step. Next slide. So a lot of these phrases here you've probably heard or said yourself. Many of you may have had these thoughts or these concerns or feeling exhausted and overwhelmed with these feelings, but are often too embarrassed to bring it up. More than 50% of women with incontinence never have discussed this with a provider or a physician. And I understand very often that it's because of an issue of embarrassment, and very often this embarrassment prevents people from getting the help that they need, and that is out there. And we're here to help change that, because it is possible to live life without incontinence, and that is not the normal for you, for the future that you have. I can tell you stories. I have friends who will be sitting with our kids, and they always complain that their kids don't understand why they have to go to the bathroom so much, or why they have to run to the bathroom or get to the bathroom so quickly. They're like, hurry, hurry, hurry. They have small children, and the children don't have to go to the bathroom, but the mom has to go to the bathroom. I've had colleagues who have concerns about going away on a romantic weekend with their loved one because they have to pack pads, or they have to make sure that they change it up, have a change of clothes, or they can't go to a concert because they don't have adequate bathroom facilities, or it's a porta potty outside. And some even executives in the hospitals who are friends who have mentioned that they feel embarrassed standing up from meetings repeatedly because they have all this urgency and frequency. And sometimes they pretend to be paged out of a meeting just so that they can go to the restroom and it not seem like they're constantly going to the bathroom because they're embarrassed. So we're here to help you change that. Next slide. So I want you to try to imagine what your life would look like if you didn't have any urinary incontinence or fecal incontinence. if you weren't limited by these symptoms, what would start changing about your life? What would you start doing? What might you be not doing now that you wish you could? Or what things might be easier for you to enjoy if you didn't have these symptoms? How would this change how you would show up every day, either to work, as a spouse, as a mother, as a wife? How does that change without those symptoms? How might you show up differently? And I want you to imagine that life without those limitations. And that's sort of what we're going to talk about today. So the purpose of tonight is for us to talk through the different options to treat incontinence. First, we'll be talking about understanding bladder control and its overview on how the bladder will work and some of the problems that can occur with bladder control. We'll kind of go over the care pathway that shows the progress or the progression of treatment options that are offered in more detail individually to treat bladder control and fecal incontinence control issues. We'll also be talking about Medtronic's bladder control therapy, which has been proven to be very effective. And then we'll wrap up by answering your questions at the end. Next slide. So one of the biggest things I want to reiterate, and I cannot say this or stress this enough, is that you need to know you are not alone. Overactive bladder, or that acronym you see there, OAB, and fecal incontinence, the acronym FI, are both extremely common. There are over 12 million people in the United States alone with vision problems and 17 million with asthma. If you combine both of those numbers together, you still wouldn't have the number of Americans who have either overactive bladder or fecal incontinence. And if you might be asking yourself, if this is such a common issue, why have I not heard about it? Well, many people don't talk about this. As in many things in my world in gynecology, they don't talk about this to their friends or to providers because of how embarrassed they feel about it. So they often never bring it up. And so it stays hidden. Like vision problems, like asthma, bowel and bladder issues can happen to both women and men of any age. So it's not just associated women, and it's not just older women, young men, older men, any spectrum in between, it can happen. Although your risk does increase as you get older, I want to reassure you that does not make it a normal part of aging. And it is not something that you have to keep living with or that you have to leave untreated or continue to ignore. One of the interesting things is that one of the things that most brings people in is that they're tired of getting up at night. They're exhausted. I can't tell you how many of my patients walk through the door and they tell me how exhausted they are, or they're not sleeping well because they have to get up over and over and over and again. That causes decreases in productivity and revenue. And then for my elderly patients, overactive bladder becomes an independent risk factor for hip fracture because they're getting up so frequently at night and it's dark and they have rugs or cords and they trip and they fall. And then they have a hip fracture, which I'm not sure if you are aware, it can be very detrimental and life altering, and is one in 3 women who have a hip fracture will die in that first year of a hip fracture from complicating events from that hip fracture. So it's a very big complicating factor that if we could just help treat overactive bladder would make it less common and also less of an issue for fall. Next slide. It's really important that, again, I repeat, and you're kind of going to hear me banging this drum, is that this is not a normal part of aging or something you have to live with. I'm sure a lot of these symptoms may sound really familiar to you. Frequency and accidents, getting that I have to go feeling, and you have to go at that very moment. Having to monitor how much you eat or what you drink. I'm Colombian. I love coffee, and we'll go over this later. If I have to have coffee in the morning, but that also increases the amount that I have to pee. I have patients who say they give up something like that, they have to give up their coffee, and that would be, so sad for me, and I know for a lot of my patients. So I want to make sure that you can get to enjoy coffee again. Planning activities around a bathroom, not being able to take kids to ball games, because if your child's in travel ball, they're porta potties, or they're not close bathrooms from one field to the next. And then you don't get to enjoy and be there for your child. Just a host of stories that I've heard, that hopefully we can assure you that this isn't normal and that we can do something to help. And as you're listening to your body, improve some of those symptoms, and not be fearful of having accidents. Next slide. So let's go over how the bladder works. Often in learning about how something works will empower you to understand where things are maybe not functioning the way they should, and empower you to make the next step to treatment. So to understand what your body is saying, we talk about the bladder function itself, and it involves the coordination from the brain to the muscles of the bladder through nerve signals. As your bladder fills up with urine from the kidneys, it tells the nerves in your brain that it needs to be emptied. And then your brain assesses its surroundings to decide whether or not is this an appropriate place to evacuate your bladder, or is it something that we need to hold? As we research incontinence of the bladder, we understand that there's poor bladder to brain communication, and it can be on a host of issues, either because you've had some damage to the brain, some damage to the nerves, to the bladder, or the bladder itself. Next slide. Similarly, bowel incontinence works from a brain bowel communication so that they can work effectively. The bowel works to function to move food that you've eaten through the digestive system, which usually takes anywhere from 1 to 3 days. And the muscle contractions of the intestines themselves force food or squeeze food in a forward motion through nerve interactions from the brain to the bowels. In each section of the small intestine, large intestine, stomach, and sphincters that connect the two, and act like valves, open and close based on nerve stimulation from the brain. A lot of that happens without us being able to control it. They're done by involuntary muscles, but we do have some voluntary muscles, like our swallow function, and then our ability to hold stool in through a muscle called the anal sphincter. And then we tell that sphincter to contract or relax, again, by our brain assessing the situation and the surrounding areas to make sure that it is a safe or appropriate place for us to release our bowels. Keeping these brain and bowel and bladder communications consistent and together are how we're able to treat a lot of the issues that may be connected with incontinence of either the bladder or the bowel, and ties a lot of the treatments that we have available for you. Next page. So what's incontinence? Incontinence, or what causes incontinence? And like I said, it can be a host of issues. Daily habits, I mentioned coffee. That is one of my loves and my joys. And if you told me that I could not drink coffee every morning, I would be very sad. And I know that there are a lot of patients and friends of mine who are the same way. I love to exercise every day. And so if you told me that I was unable to exercise or I didn't want to exercise because of embarrassment, because I was losing urine, that would also be very detrimental to my activities of daily living and how I enjoy life. Causes that might lead to this are trauma to pelvic organs, either through surgery, radiation for malignancy or cancer. And most common, or the thing that women are most in tune with, are trauma after childbirth, whether it be muscular or nerve damage. As we get older, we also may accumulate other medical conditions like high blood pressure or congestive heart failure. Those medications that are used, the number one treatment for that is a diuretic, or a medication that removes water from your blood vessels and helps you pee them out, which makes you pee more frequently. The more frequently you have to pee, or the more frequent you fill up your bladder, the more that you may have a chance to have incontinence. Also, medications that are either sedatives, painkillers, or any kind of nerve dulling medication will make it hard for your bladder to be able to sense that it's full, and that can lead to incontinence. Diabetes is also very common, and that causes not only the increase in frequency of urination, but also nerve injury. If you have recurrent UTI, you can also have something called that can worsen your incontinence, something called functional incontinence, where the disease process itself, Parkinson's, multiple sclerosis, a stroke, makes it functionally hard for you to make it to the bathroom in time to be able to use the bathroom without having an accident. And definitely my teachers, God bless my teachers and nurses and long distance drivers, all those professions that require you to hold your pee because there's not an appropriate or a good time to stop to use the restroom because you're in the middle of something. Those patients tend to have higher incidence of incontinence and overstretching of the bladder or damage to muscle or nerve injuries of the bladder because they've had to hold it as part of their occupation for a long period of time. So those are some of the causes for incontinence. Next slide. There are, in general, 3 common bladder control problems. The first one is stress incontinence, and that by far is the most common. Urinary retention will be the second one we cover. And then third would be OAB or overactive bladder, and we'll cover them in that order. So let's take a closer look at each one of them. Next slide. So what's stress urinary incontinence? This is the incontinence where you cough, sneeze, laugh, and you lose urine or leak urine. That increased pressure in your belly is what causes you to then have the inability to hold that pee in at that period of time. This is also when for me, I cannot go to trampoline parks with my children because I am unable to do that without having an accident. Jumping on trampolines, jump ropes. For some of my patients, it's running. For some of my patients, it's intercourse. So positional changes in intercourse, which then makes them not want to have intimacy with their spouse, which is life altering, not only emotionally for them, but also physically. That is something that is often not talked about, even in the realm that I work in gynecology, that how much of an effect this has on sexual intimacy, which is of great importance to make sure that you have good sexual health. Stress incontinence typically happens when you have a weakened or damaged pelvic floor. The pelvic floor itself is like a bowl made together of nerves, muscles, and connective tissue called fascia. And when this gets injured or weakened by any of the mechanisms that we talked about, it will cause incontinence with this increase in pressure or changing of the angle of the urethra, which is the tube that connects the bladder to the outside world. Next slide. Urinary retention is that second one we said we would be mentioning. Urinary retention happens when you can't tell that your bladder is full. So the nerves that innervate the muscles of the bladder are unable to sense that it's full and tell your brain, hey, you need to evacuate the bladder. We need to empty so that we can fill it back up. This can be extremely frustrating and often leads to a weaker dribbling stream because you cannot contract, and will require the use of a catheter or a device that we place into the bladder to empty the bladder every so often so it doesn't bust open realistically. So we want to make sure that happens, that our bladder is constantly emptying. And so that's a very large problem and incredibly frustrating issue for many people. Next slide. And then overactive bladder. This is, I gotta go. You are able to, it has a couple of components. The first is that urgency, that overwhelming need to urinate right now. And it can happen with or without incontinence. I have patients who are like, well, I don't necessarily lose urine, but I definitely have that frequency. I definitely have the urgency of, oh my gosh, I have to go right now. Is this still something that I need to treat even though I'm not incontinent? Absolutely. You shouldn't have to have that overwhelming sense of feeling or the frequency. Normal voiding is about 4 to 6 times a day. If you're going more than that, that is abnormal and something you need to bring up to your provider. And then nocturia, which is the big word for getting up at night to pee. If you're getting up more than twice a night to pee, that's also signs of overactive bladder and something that we can do something about to help with those symptoms. Because again, if you're getting up over and over at night, you're not getting that full REM sleep. If you're not able to hit REM sleep, you're going to be constantly tired, and that drained, exhausted feeling is going to decrease your productivity at work and decrease the way that you show up every day to the people that you love. And so it is our job to work through these symptoms and help you find the therapy that works for you and see if any of these may be overlapping with another kind. This is not an all either 1 bucket, 2 bucket, or 3 bucket. It can be a mixture of these. And so our job as your provider is to kind of talk to you and sort through these symptoms to help find the therapy that fits your needs the best. Next slide. And then fecal incontinence is one of those that I feel women are the most embarrassed to come speak to me. And I can only speak about women in my office because that's what I see, but I know that is also a big issue for men from my sister practice, advanced urology. It is most of the time when bowel incontinence happens outside of a infectious cause or that you ate something you shouldn't have. So this is bowel incontinence. Bowel incontinence usually, if it's going to happen, will only happen with bouts of diarrhea because you either have a GI bug, you're lactose intolerant, you aren't able to eat it, you had your gallbladder out, and then now you ate French fries and a hamburger, and that gave you diarrhea. But chronic fecal incontinence, that's different. This is a recurrent condition, and it just doesn't go away. People with chronic fecal incontinence feel that same overwhelming urge to go to the bathroom. And it happens so suddenly that they are unable to reach the bathroom in time. And that's why they get the incontinence. Sometimes it's a small amount of urine of stool. Sometimes it's a large amount. There's another type of fecal incontinence that happens when people are unaware that they need to defecate and they can't feel the urge to go to the restroom like everybody else, but they just look down and they go, oh my goodness, I have stool in my underwear. And that's called passive incontinence. And some of the therapies that we're going to talk about are going to be really extremely beneficial to both of these. Fecal incontinence can also have other similar symptoms like diarrhea, constipation, gas, and bloating that may be associated to your diet or other medical issues. But if you're experiencing these symptoms, please, 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 this is not something you have to live with, any of these symptoms. And, please seek one of our providers, and we want to be able to give you some options. Next slide. So from the beginning, we talked about what would this look like. I want you to kind of go back to say, okay, what would this life without these limitations that I'm putting on myself? And oftentimes what I find from patients or from friends, and even from family members, is that they have slowly been boiled into these changes in their lifestyle. They had no idea that they were rerouting their lives, what they were doing on a daily basis around a bathroom. It had just become so integral to their life that they didn't even realize it until they sat down and talk to somebody about it. The great news is that these are all very treatable conditions. And specifically over the next few minutes, we're going to talk or focus on overactive bladder and fecal incontinence. Next slide. Okay, so let's find our way through this. There are a lot of ways to treat overactive bladder and fecal incontinence so that we can get back to living that life or that we used to live, or that you are in the last few minutes have envisioned what it would look like or feel like to not have to reroute your life around this. There are a number of steps involved in finding what the best treatment is for you. We're going to start from the most conservative, least invasive, and then I tell patients it's a spectrum, and we will work our way through more advanced therapies as we progress through. We'll look at each one individually and remember that every person is individually unique, and what works for one person may not be the same that works for another, and may not be what is exactly right for you. So this is really just I encourage you to have this very honest and open discussion with your provider when we talk about what your symptoms are and how we are going to find the best therapy for you. Next slide. So the most conservative or easiest is lifestyle changes. And these can be very simple. Up there it says diet, exercise, physical therapy. And that's like when we tell patients, oh, just diet and exercise. But I kind of want to go into these a little bit with you so you can kind of see how these may be something that you can do as a daily habit to improve your symptoms just starting today, like right when we hang up. The first is your fluid management. Drinking, you want to drink 6 to 8 glasses of water a day. We know that that's healthy for you. And especially if you have a lot of health issues, it's just in general really good to drink that water, but maybe avoid drinking large amounts at one time. Avoid combining it with alcohol or caffeine, especially in the evenings. Changing your activity to avoid foods that would irritate the bladder, or your diet to avoid foods that would irritate the bladder. For example, carbonated beverages, spicy foods, things that are preserved in citric acid. So any canned goods or pickled vegetables, anything with orange juice or citrus like lemons, limes, anything with tomatoes, any of these artificial sweeteners. And then obviously I mentioned already alcohol. If we can remove these, and I always tell patients, it's not no forever, but just no for right now, as we are rearranging some things to help your bladder get back to a healthier point. And then introducing them back in moderation once we've given our bladder time to not be irritated anymore, so that urgency and frequency can get better. Then we can add them back in. But having that conversation, those are some simple things that you can cut out. People ask me, well, how long? Well, realistically, use our bladder on a daily basis, all day, every day. So it's not going to heal as quickly as something that you don't use on a daily basis. So it can be 3 to 6 months where we are cutting back significantly, if not completely cutting these things out, especially if you have an irritated bladder and having painful bladder syndrome, and then adding them back in slowly as the bladder has healed. The other is something called bladder training. I like to say it's potty training for adults, but it's where we are retraining our bladder to not be overstretched again. A lot of my nurses and teachers who have held their bladder until they just could not hold it anymore and then went to go pee have often overstretched their bladder. So in the beginning, we talk over a 3-week process of peeing every 2 hours while awake, setting it by a timer, whether you have to go to the bathroom or not. We do this with children. If you've ever potty trained a child, even if they don't have to go to the bathroom, we go take them to the bathroom, have them pee. And in that process, they learn how to listen to their bodies to learn when to pee. The whole process of potty training is so that you can have the child become aware and to the biofeedback mechanisms of their body again to know when to pee before it's too late. So going every 2 hours for a week while awake, then moving it up to 3, then moving it up to 4, and never being more than 4 hours while awake without voiding. And that's, those are some very easy lifestyle changes that you can do. And then physical therapy. One of the misconceptions is that physical or pelvic therapy is what gets rid of incontinence. And it works really, really well, if you may recall from the slides before, that stress incontinence is a weakness or a defect of the pelvic floor muscles. And it works really well for that. It's not great for overactive bladder, not to say that pelvic floor therapy is not great for many things, but that's just not one of the best ways to train or have therapy for overactive bladder. For fecal incontinence, it may involve physical therapy. There are a lot of great exercises to strengthen the sphincter and pelvic floor muscles to help you with that. So, that's also very conservative management for that. And these are things that you might already be doing. And so now you'd like to know what the next step is, but these lifestyle changes may not work for everybody, or you are just ready for the next step. So let's talk about what that looks like. Next slide. Oral medication. So if we're going from least invasive, most conservative lifestyle changes to the next most advanced therapy would be medications that we can take. These oral, when lifestyle changes fail to give you the results that you want, we start with medications, and they're kind of 2 big buckets that I tell patients that these fall into. The first is something called an anticholinergic. These anticholinergics control the bladder and are often used for antidiarrheal medications for bowel control. And they work on the muscles, not the nerves. They work on the muscles of the bladder and the bowel. And these are smooth muscles to help control some of the symptoms. And they are taken daily. And however, I always try to warn patients of unpleasant side effects. I'm one of those people who have been blessed that I'm going to get every side effect on a medication list that there is. And I have some patients that are just like that. And I think that I was given that so I can really empathize with patients. So, if there's a side effect to be received by medication, I am going to get it 100% of the time. So for these anticholinergics, these drawbacks or side effects are going to be dry mouth, dry eyes, and constipation. And these can be really unpleasant. And especially for my older patients, they already kind of struggle with this as it is, and they already are a fall risk as it is. So we're going to make their vision blurry, make them have dry eyes, make their mouth dry. They already have issues with dry mouth because they're on blood pressure medication, or they're on or diabetes medication, or they just aren't getting enough water because they're trying to not drink so much water. So they don't have incontinence, and then constipation, which is made worse by all of those. So these are some unpleasant side effects. And one of the biggest one that I want to like kind of bring up as the last point is that for some of my older patients, I really try to avoid anticholinergics because it's been shown to have some issues with dementia, confusion, and memory loss. A recent study in the National Institute of Aging showed that these patients who take anticholinergics have a greater risk for developing dementia. And that for me is just having parents of that age and they live alone. I really don't want that happening to them. So I always try to warn patients about these side effects and what to expect and how long to expect them. These are side effects that you deal with them for a short amount of time, like some medications, and then they get better. Most of the time, once you get them, they kind of stick around. Next slide. So what's the ante above that? What's the more advanced therapy? So we've tried lifestyle changes. That hasn't helped. We tried medications and that hasn't helped, or the side effects were too much and we couldn't handle it. What's the next step? The advanced therapies that we're going to talk about next for both bowel and bladder control, or what is next. So let's go over some of these and some of the pros and cons of that are associated with this. So the first one for bladder control is the sacral nerve stimulator that is created by Medtronic, or called InterStim. And the other is injections, Botox injections into the bladder that work just like the Botox we put on our face for wrinkle control. They help relax that muscle. Remember, our goal is to take some of those spasms away, relax that muscle. And you have to, obviously put Botox back in because it wears off over a period of time as your body breaks down the botulism toxin. And so you have to get it repeatedly placed into the bladder. So there's a lot of treatments with that. And for bowel, there are really only two treatments: InterStim for fecal incontinence, and then surgery where they reconstruct your sphincter, called a sphincterplasty, which is pretty major surgery in and of itself, and quite an unpleasant recovery. Next slide. So Botox, like I mentioned, is injected to treat overactive bladder temporarily and requires frequent visits to the office. So we do this in office at our office. We have an in-office procedure room where we can use a flexible cystoscope, look inside your bladder, make sure there aren't any injuries or defects in the bladder or lesions in the bladder, and then we can systematically go through and inject the bladder wall with Botox to help relax some of those. Just like oral medications, the injected medication focuses on relaxing that bladder muscle, not the nerves. Again, we're only talking about muscles, just like with medication, not affecting the nerves that connect the brain to the bladder. And once it's paralyzed, then that muscle has been able to relax and hold more urine without the ability for it to kick back, which when you feel that kickback or the sudden urgency and lose urine, that's what we're trying to avoid. If you used injections, you might be more susceptible to urinary tract infections. And the other side effect is that you may have to self-catheterize yourself. So we might numb the bladder up and then it's unable to contract at all. Remember, we talked about that middle kind of urinary control issue called retention. And if your bladder can't contract at all, then it also cannot empty and you have to catheterize yourself. And the injections are typically only as effective as the oral medication, which is why many people after 2 treatments are like, I'm not coming back to this. So the next treatment or advanced therapy up is the sacral neuromodulation. Next slide. So InterStim is the name of the system. And this therapy gets its name because it provides relief and restores bladder function by gently stimulating the sacral nerves. So we talked this entire time for therapies that talk about helping with the muscular component of the bladder. And now we're going to talk about, before we even get to the muscle, the nerves that come from the spine through the sacrum to innervate the bladder itself. Medtronic bladder control therapy, which is delivered by InterStim, uses gentle nerve stimulation to control that bladder and brain communication pathway and help restore the function of the bladder itself. And as a side note, I want to let you guys know that this therapy has been around since 1997, and it is completely reversible. It's one of the only therapies that helps restore bladder function in itself that you can test drive, which is great. Like if you're going to buy a car, you are going to want to test drive it. And this is one of those things that you can be able to see, does it work for you before you actually get the full system in. Next slide. So let's talk about the test itself, this test drive that I just mentioned. So before insurance will pay for this therapy, most insurances, including Medicare, which does cover it, we have to do a test phase in order to see, is this going to help you? Are you a good candidate? So we've documented that we've tried all these other things, and then we want to do a simple test to see, are you improving your symptoms? You do a bladder diary before, we document what your symptoms are like before, and then we compare it to your bladder diary afterwards. The test lets you try this therapy, see if it works for you, and you and your doctor will look at the information and see, is this really a great fit for you? Most people see results within the first day, which is pretty amazing. Unlike other treatments, this therapy lets you try it first without the long-term commitment. And at the end of the test, you have a really good idea as if this is going to be what gives you the best relief or not. Next slide. I get a lot of questions about, is this something that's safe? I want to make sure that, is it effective? Like, can you give me some numbers? I have a lot of university professors, because I work with a university, who love facts and figures. So I love to give facts and figures so I can give some real life numbers to patients to really go home and chew on. So 89% of people using the Medtronic bowel control therapy experience long-term success. 89%. That's significant. That is a significant and powerful number right there that tells you that these quality of life improvements are making a big change. 76% of people achieve success with InterStim bladder control compared to the 40% with medication. So huge, almost double the amount of people who are doing the sacral nerve stimulator talk about long-term control and improvement of quality of life over less than half, like less than flip of a coin with oral medications. So the data is important. And to me, numbers speak for themselves, especially for my patients. And so I love this slide and that it gives you those numbers to chew on. Next slide. So what makes someone a good candidate for this? As we've mentioned before, it's not uncommon to have patients who have both stress urinary incontinence and overactive bladder, or most, and we get asked all the time, is there one that we need to do over the other? You can have, if you have significant overactive bladder symptoms like urge incontinence or urge and frequency, or if you have a non-obstructive, and nothing, that the reason that you're not able to pee is because something's blocking that path, but and that it's a issue not blocking it. So non-obstructive variety of urinary retention, this is a really great therapy for you. Or if you've tried multiple lifestyle changes or oral medications, by the time people get to my office, they've usually seen 4 providers and have tried medication after medication after medication, or they've been told lose weight, diet, and exercise, and that's it. And that's all they've been given as options. And they come so frustrated, like, why even bring it up one more time? I highly encourage you, just bring it up one more time, because we have the ability to give you another option. Most importantly, if you're not getting the kind of relief that you want, and you want your life back, or that life that you imagined earlier in this presentation, if this sounds like you, then that's the first step in the typical evaluation that we do at our new patient appointments. Next slide. So my patients are super excited to be able to get some of their life back. It says, I'm getting back to doing the things that I love, and that means everything. I want you to envision that for yourself tonight. I am confident that that we can look at this together, and beyond excited to partner with you and my staff to try to get you the results that you've been looking for. I'm sure you guys can get this link, a link on our website later to look at this. But I'm always surprised at the number of providers and patients who don't know that this therapy exists. In our office, we have 13 years of experience with InterStim. We are a group at Advanced Gynecology, together with our partner Advanced Urology, do some of the most InterStims in the country. So I want you to know that you're in the best hands to be able to get the results that you want. Next slide. And that's it for me. Adrienne.
Dr. Millan, thank you. This is Christy from Medtronic. Thank you so much for tonight, for all of your time, for just articulating things in a really understandable way for us. There were several messages that I got from tonight, which is just, number one, I'm not alone. Number two, there is a treatment algorithm and you're going to walk me through it. And there might be a conservative way to help. But then there are advanced therapies to help me as well. And I can't thank you enough for walking us through everything. I'm going to read off the phone number to their office. And Dr. Millan did mention that they even do have same day appointments. So to that point, real quick, before I read off that phone number, I'm going to share the results quantitatively, again, without anybody's information shared, of that poll that you took earlier. If you look at that first question, do you struggle with basically voiding dysfunction? You know, are you leaking urine or stool? Are you wearing pads? Do you go more often than you want? 80% of you on this call tonight said yes. You're not alone. And then the 28% of you might have joined because you know somebody probably who struggles with this. We're thankful that you joined. We're thankful to you, Dr. Millan, that as you mentioned earlier, you know, this isn't a new therapy, but we do depend on physicians to educate patients. And so we're just grateful that you offer free education for us. That second question, have you tried medications or supplements for your condition? 60% of you said yes, and yet you still joined tonight. That tells me that you're probably not getting the relief that you want. 40% of you have never even tried. So you're earlier in that treatment algorithm, and maybe something will work for you, you know, prior to trying InterStim. That third question, 60% of you had never heard of InterStim prior to tonight. This therapy has been around for far too long for that number to exist so high. So again, thank you, Dr. Millan. And then that fourth question, this is really cool. Would you like to discuss your condition with a provider? 40% of you selected different times to make an appointment with Dr. Millan. And so now I'm going to read that phone number off so that you can make an appointment. It is 678-946-2706. And Dr. Millan mentioned something earlier. She keeps saying the word sister practice. So she practices out of Advanced Gynecology, which obviously only would treat and see women, but there's Advanced Urology, and that treats both men and women. And so if you're joining because you have a spouse or a loved one, or know somebody, you know, family member, whomever, that's a male and wouldn't obviously see Dr. Millan, she can easily refer you to somebody within their practice, to their sister practice, so that they can get help. So thank you for letting me share that. I'm going to pass the mic to Adrienne, who's now going to get to y'all's questions, and they're just going to popcorn back and forth between one another. We're going to leave this slide up so that you remember and can write down that phone number. And then I'm going to stop recording, or Adrienne might already have done that. And nope, I'm going to. And